in the ears, 50/45 in the throat, and then 90 in the lungs. And those 90s are being divided Q12, and so you end up having 40 to 45 per dose on those. So just remembering the 90, 50, 90 rule really helps me remember going down from ears to lungs, what dose to do. And then of course there are different durations too. So making sure you're treating for the full course is important as well. So there you go. Again, strep, as you can see for strep throat, the age 3 to 18. So strep throat is very debatable. And I know Heather did a great grand rounds on strep infections. Specifically, she talked about how strep throat less than 3 and especially less than 2 is very unlikely to be your diagnosis, much more likely to have a viral process going on. And a lot of times we see that in our continuity that they're actually doing strep tests for younger ages, and oftentimes they're carriers, and that's not really what's causing the problem, but they get treated anyways. So just keeping that in mind. Okay. And then really just, sore throat is such a common complaint in clinic and what we see even in the emergency room. And so it's important to know, what's really serious for strep throat. And so this was a really great table from Up to Date, and I just put sort of highlighted some things. So of course, infants and young children, just like I was saying, group A strep, as you can see, doesn't have the little star by it. It's not the most common cause in infants and young children, but it is in older children and adolescents coming over to the right side. So more likely in infants and young children presenting with sore throat, it's going to be more of a viral picture. So respiratory viruses, of course, and then the herp angina. So looking at, the soft palate, hard palate for lesions suggestive of that. This, of course, was all complicated very much by COVID. So COVID can present as sore throat, as well as we know many other things. So always keep that in your differential going forward until we cure the world of it. But the big thing is serious things, especially in the ED or even in your office, that would prompt you to send them straight to the ED with all these bad stuff. So abscesses, epiglottitis, and we'll get into that a little bit more throughout the presentation on sort of warning signs and things that would make you think that these things, but just always have these in the back of your mind so you don't miss them and just chalk it up to a simple strep throat when it could be something a lot more serious. The miscellaneous things, those can get pretty esoteric pretty quick. So, a lot less likely, but do consider them. And then, of course, foreign bodies, things like that, always to be considered. So what are some of the physical findings we see with group A strep? Inflamed uvula, posterior pharyngeal involvement, that very hyperemic. Tonsillar exudate is big. So that was in our initial image. We saw some really great tonsillar exudate. And then moving beyond the mouth, of course, you have skin involvement, the scarletiniform rash. That's that sandpapery rash. It usually starts centrally and expands outwardly to the extremities. So think about that, sort of your chronicity of rash and its texture, of course. Of course, it's more of a texture thing with different complexions. The redness of the rash may be difficult to appreciate, but I'm really just running your hand over it. If it feels like sandpaper, it's very consistent with that scarletiniform rash. And
then some other things I tried to kind of touch on, at least in the question stem, was just, the association with things like nausea. You might even have kids who are throwing up, and then also the lack of cough, hence, luckily they didn't cough on you. Those are going to be kind of going back to Centaur criteria stuff that you learn about in medical school.
Yeah. Thanks, Jessica, for pointing that out. I was looking at the Centaur criteria too, stuff for this, and just always remember though, Centaur criteria were definitely developed for adults. And so there's many articles that have debated their efficacy for kids. So while you can use that as a framework, remember kids can present a lot differently. So really Centaur will probably be more applicable to your adolescents at best. Okay, so case 1 continued. By treating with antibiotics, you are decreasing the risk of blank, but not of blank. And several of you guys got this. So yes, decreases the risk of rheumatic fever, but not of PSGN. So getting into that. So the good old rheumatic fever. And for these parts, I just chose those things that help us remember test taking. So major criteria, Jones, minor criteria, Peace. You guys all know these. from med school, but the minor criteria sometimes I forget, and just remember you need 2 major or 1 major and 2 minor. So just committing these to memory, they're going to be on our boards. I'm absolutely sure of it. So just always consider that. And then PSGN, they always seem to ask for, and Stallworth always seems to ask about the complement levels. So compared to other renal conditions, nephrotic syndromes, remember PSGN, your C3 will be low, C4 may be low or normal, but C3 definitely low. And then they always like to ask, like, when will it return to normal? And C3 will return to normal 4 to 8 weeks after presentation. Sorry. So those are just some test taking pearls because they seem to like ask those.
I mean, if you want to wait, and you can even just watch.
Okay. And then another thing, they always seem to talk about like the anti-streptolysin ASO as being a part of something you can do to diagnose like PSGN. That's part of the diagnostic criteria is, you know, a nephritic involvement. You guys mute, please. Nephritic involvement, but then also having a positive or an obvious strep infection. And one of the criteria is a positive ASO. Do remember though, the ASO can be falsely low or negative in skin infections. So you can get PSGN after skin infection, but ASO may not be able to prove that. So there's actually something called the streptozyme test. And I think we have this here, but I'm not sure. And it's actually a combination of the following antibodies. So even if your ASO is negative, it should capture your strep infection with those other antibodies. So just remember that ASO is only one part, one part of the bigger picture of antibodies that could result positive with a strep infection, whether that's pharyngitis or skin. And the streptozyme is very helpful with 95% of patients become positive. Okay, so continuing on further with this case, a different case, but with a similar presentation, I should say. So this is a 17-year-old patient, exact same presentation. So had that same image of that tonsillar exudate, etc. This patient had all over been treated with amoxicillin for the past several months. So the patient says it gets a little better, but then comes back. What other bacteria do you need to consider? And people were just on it with this EBV mono, but it did say bacteria. So make sure you're reading your questions. So what could possibly this be? And these I didn't know. So that I learned someone got one of them right with gonorrhea. So gonorrhea can cause a strep-like presentation. Something must be considered, especially with those sexually active teenagers. You'd give intramuscular Rocephin. And then this is a little bit more out there, something that Dr. Norton mentioned, that you can have our Cannobacterium, which also used to be known as Crinebacterium, also has a rash, that scarletiniform rash, and that would be treated with a Zithro. So if you have this refractory pharyngitis that looks very streppy, but it's just not responding, these are 2 things to keep in mind. All right. So case 2, school-age kid, sore throat, states it's worse on one side. So that's a really good tip-off. I mean, if they're localizing it, if the kid is able to localize it to one side, you definitely want to check, and that's definitely, gonna make you think that it's something more than just a strep pharyngitis, which usually is not like you're not able to localize that. It's just my whole throat hurts. It hurts to swallow kind of thing. So make sure if they're localizing it that you take a good look, and your suspicions for other things should be up. So how would you describe this? And what findings are concerning? So let's see what people did. So yeah, obviously the kid is tripoding, so that was really good pickup. Concern for airway compromise in those case. Soft palate erythema and edema, that's really good. Inflamed tonsils. Uvula shifting. So yeah, we see our uvula has moved because of mass effect from one of the tonsils just getting so big and pushing our uvula out of the way. That's really important to recognize. And then up top, we just have our differentiation between our hard palate, soft palate, uvula, tonsils. Just want to make sure we're using all of our correct anatomy terms. You guys did a great job with that. And then on this right sort of drawing, you can see that the palate has become so swollen that it's pushing that uvula over to the side. The same thing is occurring here with the swollen palate, swollen tonsil pushing the uvula. So never a good thing. And someone had mentioned pseudomembranous plaque, and so that is what we see with diphtheria. So not in this case per se, but shown here, you can see the pseudomembranous plaques, and those are, of course, suggestive of diphtheria. That sort of white plaque causing a lot of drooling can get in the way of the airway, impede swallowing, etc. So that's usually like pathognomonic for diphtheria. And then differential diagnosis of diphtheria. So a lot of those same things. Look, there's group A strep right there. So, you know, I'm going to see if it doesn't really say anything about laterality per se, but just looking down on all the other things.
I think a nice comparison kind of between like diphtheria and group A strep even is just kind of the difference as far as like sore throat and fever go. You see that a lot more with group A strep versus diphtheria. And then it being an adherent tonsillar exudate kind of helps you out a little bit as well. Finally, kind of just the tonsillar enlargement is something you can see to help differentiate you a little bit potentially.
Yeah, for sure. All right. And then going down, other, you know, infectious mono, that can be difficult differentiating between group A strep, and that's really probably why so many times in the clinic you get group A strep swab, rapid strep versus a monospot test, because sometimes those can be very difficult with very similar histories as well. Okay. All right. So what was that? This image, it was a peritonsillar abscess. Going down, this is just a really great sort of algorithm trying to figure out what something like this could have been. And again, that typically unilateral gives you a good clue. That hot potato muffled voice, this is getting away in the way of phonation. Dysphagia, so difficulty swallowing. And then leaning forward, trying to make sure that by leaning forward with the head in a sniffing position, it may get that peritonsillar abscess in the uvula out of the way to make it a little bit easier to breathe.
And I think that this, as compared to one of the questions we have later, is just interesting because in this case, we're saying that for peritonsillar abscess, drooling would be a indication to have, reasons to control the airway more urgently. And whereas we'll see later on with a different diagnosis, that's just kind of a feature of the illness itself, but not necessarily an indication for emergent intubation or anything. And I think that, I don't know, I personally get confused between all the different abscesses in the neck all the time. Yeah. So I just wanted to point that out, that in this one, drooling is an indication, but later on we'll see that it's just kind of a clinical feature.
All right. So Jessica, I'll let you take this one.
All right. So this is continuing on with that case. So we have a toddler here who's presenting with stridor. They have pain or resistance on neck extension. And they've been in the waiting room. While they were in the waiting room, they had a lateral neck film. And you pull the film up and look at it before going into the room. What a lot of people ended up putting was kind of more along the lines of like epiglottitis. But that was not what this image was trying to show. This image was trying to show retropharyngeal abscess, which is a diagnosis that we'll see more so either in adults, which obviously we don't see, or in like young kids, like 3 to 5 years old or so. And so on the image in the left, which is the one that we used for the question, you can see a huge widening of the retropharyngeal space. So the space between the actual airway and the spine. The technical definition for when you have true like widening of this space is that it's greater than the anterior posterior diameter of the C2 or C3 vertebrae. So if you look at those and then you kind of imagine that just adjacent tissue, you can see that it's pretty much just about at that same AP diameter. Normal would be really like less than half of the AP diameter of the vertebrae for the distance between the anterior part of the vertebra and the posterior part of the airway. If that doesn't make sense, somebody raise their hand or speak up. And then on the right side, we have kind of more of our thumb sign, where that white arrow is pretty much pointing to the actual epiglottis itself. And so the epiglottis being swollen is what's pushing into the airway, and kind of like a thumb is like jamming on in there, creating that little out pushing, or the asterisk area of the aryepiglottic folds. And so you can see there's a big difference between these two things. In one of them, from the front side of the throat, you're having swelling of the epiglottis, and that's pushing things, kind of creating a funky looking airway itself. Whereas in retropharyngeal abscess, we don't necessarily see any sort of changes, or obvious changes at least, with the way that the anterior tissues look, but the distance between the airway and the vertebrae is pretty big. And even just comparing the right image and the left image, if you look at the distance between the airway and the vertebrae for that epiglottitis image, you can see it's nowhere near as wide as the one on the left with the retropharyngeal abscess. So two different lateral films that you might see, but very different diagnoses. And so try not to jump to, oh, it's a lateral film, therefore it must be epiglottitis, because there are other things that a lateral film might be showing you. All right, so when you see that, you're pretty panicked that the kid has been waiting for so long. This was kind of what I was alluding to earlier, as far as things to make you be a bit panicked and be like, shoot, we need ENT and anesthesia. So all of these are features that you can definitely see with retropharyngeal abscess. Only some of them are ones that would necessarily say, let's get ENT here now and figure out, you know, intubation and whatnot. Y'all were dead on with the sniffing position and anxious appearance. I'm somewhat surprised, I'd say, that overall more people put that is what they would, you know, that would make them want to intubate more so than severe respiratory distress. But I mean, that's good. That's, you know, the correct things to kind of look out for. And even when it's not maybe an obvious answer, it's good that y'all know that. Y'all kind of took the bait with the drooling, which is fine, because honestly, I feel like a lot of times when we write these questions, we want people to get it wrong, because that's how you learn, is, you know, making the wrong choice and then learning what the right one is. And then unable to cough and unable to speak is actually another indication for when you have retropharyngeal abscess to want to urgently secure the airway. I think the idea is kind of like that common thought of, if someone's like legit choking, they can't make sound, is kind of how I logic it out, at least. So if they can't cough and their airway is, you know, so swollen that they're not making sound, that's concerning. I thought about including unable to cough or speak in this, but since there were two, I felt like that might be kind of more confusing. Like, are we asking developmental questions all of a sudden, or what? Because honestly, most two-year-olds that I've seen in the ED don't want to talk to you anyways. And then here is the management of RPA in children. So as you can see, suspected RPA, we're gonna expect to see fever, dysphagia, drooling, stiff neck, especially with extension, and then trismus, which, by the way, all of y'all got what is trismus right. So fantastic job at that. And then after you decide, like, yeah, I think it's fairly likely. Obviously, we already had an X-ray to help us out, but eventually you might go for the CT. But first, you got to triage it and kind of figure out, you know, is this person stable, or do we need to get ENT involved? And so the signs of severe airway obstruction would be any of those things. So tripod or sniffing position and panicked appearance, which again, all of y'all answered that. So great job. Severe respiratory distress with poor air movement. Cyanosis, I did not think would be worth including because that one seemed a bit obvious. And then also unable to speak or cough. So that's kind of an uncommon thing that we see, but definitely something to be aware of. All right, case 3. So this is for somebody on nights. Your intern on nights, a total know-it-all and stalwart wannabe, tells you they are concerned about Lemire syndrome in a teenager with throat pain that you just had them see. What do you know about this syndrome? Because honestly, some of these kind of funky syndromes, it is like, shoot, do I know anything about that? And I very, very, very much appreciate the person who honestly just put nothing at all. Because sometimes you don't, and that's fine. Somebody puts septic thrombophlebitis of the IJ vein caused by anaerobic fusiform bacteria, usually secondary to displacement of from some sort of pharyngeal infection. That is like perfect textbook definition. Excellent work. I love that, you know, we also, some people were mentioning like adolescent patients and then the specific bacteria type. That's awesome. And so then just kind of some other high yield points with Lemire syndrome. One, Stallworth really likes this one. And I think that's a lot of why we ended up including it, is because he's drilled it into our heads a couple of times. So like we said, septic thrombophlebitis of the internal jugular vein. Typically it'll begin with an oropharyngeal infection, usually within about a week is when you would see this. It's more common in otherwise healthy young adults. The common pathogen to know for it is Fusobacterium necrophorum, which is an anaerobic gram-negative bacillus. So they'll have fever and unilateral neck pain. They'll also have exudative tonsillitis, sore throat, dysphagia, and trismus. This actually, I think from that would be somewhat difficult to initially differentiate potentially from peritonsillar abscess. So definitely something to have in the back of your mind, especially if there's other like weird presentations. Complications, pulmonary is super, super common because you'll get septic pulmonary emboli. So obviously you shouldn't really have any pulmonary involvement with just like straight up peritonsillar abscess or anything, but that would clue you off that something's awry. And then treatment would be piptazo or carbapenem, or row and flagyl, plus or minus make. But that, I think if you are dealing with Fusobacterium necrophorum, ASP will be involved. And then here is just a nice diagram of all the things that are happening. So we have oropharyngeal primary infection with pharyngitis or tonsillitis or peritonsillar infection or abscess. Even dental step or EBV could also kind of have like a co-infection picture. And then because of all that inflammation, you're essentially kind of, I would just think of it as hypercoagulable, at least in that area. And then you can have septic emboli. Because of the location, it's going to be, you know, I mean, with anything venous, it's going to go to the lungs first, but other places could happen. All right, we are done. So we have some jokes, but to mix it up a little bit, we also made them hangman style if you want to do that. So for people who are in groups where they could play this if they want, nominate one person to run it if you like, and then they can text me and I will tell them what the answers are so that y'all can play. As you can see, we've got 3 different ones. One is, what did the Pilgrims use to make cookies? For that, the first word is 3 letters. Second is 5. We also have, what do you call a rabbit with fleas? And then the first word is 4 letters. The second word is 5 letters. And then finally, we have, what do you call a fish wearing a bow tie? For 13 letters. Good luck. All right, thank y'all. Bye.
What do you want? What do you want?
Um,
How is it? You like it? I requested that for next year.
you learn a lot.
Really? But to do notes? Yeah.